When someone comes into your office with trauma, there's a vast array of what you might see in their presentation, right? They could talk about having insomnia. They could talk about chronic pain and headaches, depression, shame, self-hatred, startle responses. There's almost this infinite number of ways that trauma shows up in the office. And as we'll talk about moving forward, clients don't always recognize it. Often they just think, oh, I can't sleep at night, you know, and so I smoke weed, you know, or drink alcohol, or, you know, whatever ways they've learned to self-medicate, right? And we even find that depression is a response to trauma.
To really help us understand and remember how trauma impacts patients' lives. Let me see, I have to look at this because I can't see, but it shows you 4% more likely to become an alcoholic, 15% or 15 times more likely to commit suicide. So just wanted to kind of reiterate how important it is to identify and treat trauma. The trauma-informed therapy really is an attitude, an outlook, a lens where we recognize the impact of trauma on all of life's experiences and on relationships. We recognize the impact of trauma on the relationship to the person's sense of self, their sense of others in the world, and just their sense of the world. Traumas, especially developmental trauma, affects and molds the working model for which clients perceive everything else. And so it becomes very important to look at our clients through an attachment and developmental lens. One of the first tenets of trauma-informed therapy is safety. Safety first. But often what we're seeing is clients going into treatment, individual or treatment programs, and just jumping into the reprocessing part of the trauma and really getting re-traumatized. So knowing how to start the first stage, which we're going to talk about in a minute, but our first priority is to keep people safe and to stabilize them and give them relief from all of the many symptoms of trauma that were shown in the previous slide. Trauma-informed therapy also looks at thoughts, feelings, and behaviors, emotions, not just as something to extinguish or change, but we want to look at the protective value of these thoughts, feelings, behaviors, emotions. Because developmentally, if there has been childhood trauma, not only is the central nervous system affected, not only is the person's self-image, their attentional system, their motivational system, their social engagement system, but the actual structure of the brain is affected as well. And when that happens, the ability to self-regulate and self-soothe is compromised, and when that happens, the person must develop survival strategies in order to get through life and get through the world.
When therapists are providing trauma-informed care, SAMHSA kind of outlined and created this simple sort of organizing principles, right, that we really want to pay attention to the safety. Right, clients who come in with experiences of trauma, most often, bottom line, they don't feel safe in the world. They didn't feel safe in their family of origin, they didn't feel safe growing up through school life, and they don't feel safe in the present moment, right? And so that first key part, and again, we'll keep bringing this up, but helping that client establish a sense of safety within themselves, in their bodies, in their feelings, and in their thoughts. Clients need to be also feel that they can trust you, and that we use the word transparency, but feel a real authenticity from you. So often in their lives, they've experienced someone who says one thing and does another. You know, I love you, bam, right? And it's like, that's so confusing. And so in the trauma therapy treatment, being able to establish in the room that, like, yes, you can trust me. You know, I am here to collaborate with you, and I'm going to show you my authentic self. Peer support can help normalize. Clients often feel like they are the only person who's experiencing this kind of a pain and trauma and despair. I mean, it's kind of one of the fundamentals of like 12-step programs, right? That sharing of that experience just helps a person not feel so alone and so isolated. And then that also the sharing and the witnessing of each other. So it helps both normalize and it helps in the treatment process, being able to, you know, as they move through treatment, hopefully share with less shame, right? Because they're not disgusting. It's not something that no one else in the room has experienced. And so with a really, you know, great group facilitator, they can help create this peer support that's containing, right? We can't have groups where people are traumatizing each other either. So that's the other fundamental you have to pay such close attention to with groups, is being a good container for the clients so that they feel the safety in the group and the trust in the group. And then I touched a little bit, but the collaboration and mutuality, like, we're in this together. I'm not the expert who's doing this to you, because that doing it to you, there's a victim quality to that at times, and a lack of agency. So we want the clients to experience agency and empowerment in terms of this mutuality and this collaborative process. Helping our clients find a voice and to be able to experience this choice of like, yes, these things happened to me in my past, but what's going to happen to me in the present? How am I going to live my life so that I have more empowerment, agency, and choice?
We don't do to the clients. We're not the experts. We have to have an attitude of curiosity and really exploring with the client, what is that reaction? What's going on with that right now? Because we don't know. And we are not sitting up here on a throne doing something to you, as Lynne said, but we are exploring together what can be new possibilities. And triggers can be internal or external, so it could be a thought, a feeling, or an emotion that can be a trigger. Sometimes feeling good can be a trigger for our trauma clients. So a trigger could be something that's conscious. Someone might know they're triggered, but it could also be implicit or unconscious, and the client has no idea what just happened, or that they are triggered. They may not even recognize the shift in their state, or that they've become agitated or hyper-aroused. Even very small changes in the affect, behavior, voice, tone of voice, movements of the client helps us to recognize triggers. And through that, we together can help the clients recognize, because often they don't know. Often they can't feel. Many of our clients are so dissociated that they don't feel the sensations in their body.
Dissociation has various levels too. There's the person who dissociates right into a DID, personality disorder, and then there's the person who dissociates, meaning that they're thinking the cortex is not working anymore, and that can happen when someone's flooded, that they're just so overwhelmed by all of that they're in a state where they're not able to think anymore. So there's various levels of dissociation. Attention, attunement, that's why it's so important that trauma-informed therapists have the capacity to work in the right brain, right? Because if you're all just in the left brain, then you're going to miss all those nuances of shifts in body and the eyes and what they're hearing and not hearing. So just to kind of identify a little bit these differences that you might have to work with if you're working in a treatment program or in individual therapy only. And so in a treatment program, there is the risk of moving into the trauma too quickly. If somebody's in a residential program for 2 weeks or a month, really even 60 days, or in an IOP level, the importance of really making sure, and we'll come back to the stage model, but really making sure that you don't move too quickly, because clients sometimes want to just get in there and get it done, but if you don't have the safety and the trust and all of that base established, then it can be very dangerous, and clients can have a really huge reaction to moving into the trauma too fast. We've seen clients who, heard about clients who become catatonic almost and end up treating clients who've gotten re-traumatized because they went too quickly into the trauma. So that's really important to pay attention to. And then also really paying attention to staff in treatment centers. Like a lot of the staff are also trauma survivors. And so being able to help them recognize their own triggers in the work. A client might be what's called resistant, but really they're not resistant or defiant, it's their own defense structure coming up. But then the tech person or the untrained a person on site might respond in a angry way because they feel the person's being defiant, and then it triggers them, and then they trigger the client, and it's bouncing back and forth. And so therefore, so important that the staff be trained to know how to work in those environments. Even if, sometimes the admission might be doing biopsychosocials, but listening month after month to the intensity of some of these experiences can be really triggering to that staff person. So like what Nicole was talking about, the staff care, like really making sure that they're being taken care of and that they're aware of what's happening in the environment. Complex PTSD psychotherapy could take a year, 2 years, 3 years. I mean, it's just unknown when you start off how that's going to work, but to be able to move at that kind of a pace. And then also making sure that if you are a therapist doing that kind of treatment and you become aware of developmental trauma issues, and if that's out of the scope of practice, to be able to collaborate with a therapist who has that specialty, because a lot of us will collaborate with therapists who work in different modalities, and it's so important to be able to get that extra support or your own supervision or something like that.
The infant's nervous system develops through interaction with the mother, through right brain communication, through the mother's eyes, the gaze, the touch, the prosody of her voice. So affect regulation is the capacity of an individual to regulate their emotions. Infants are born with absolutely no capacity to do this. The infant is regulated through, I'm going to keep using the term mother, but primary caregiver. So the mother's job is to regulate that little newly forming nervous system and brain. So when this goes well, when the mother is attuned to the infant and can meet that infant's needs for connection, for feeding, for touch, the central nervous system and the connections in the brain happen in a certain way, in a healthy way. When this does not go well, those connections, those necessary connections, the start of self-regulation don't happen. And so the infant, instead of developing the capacity to self-regulate, instead develops, again, survival strategies. And what do you think is one of the primary strategies an infant would have? They can't fight, they can't run away, they shut down. They shut down. The earlier the trauma, the more dissociation we're going to see in life. Affect regulation theory is a right brain to right brain type of psychotherapy, again, where we are listening to our own bodies, being duly aware of what's going on inside of ourselves, as well as what's going on inside of the client. So we're paying attention to their words, but we're also paying attention to the implicit messages they're giving us, the unconscious messages. And as I talked about earlier, that we're going to notice what we're feeling in ourselves. We're going to notice if all of a sudden I feel like I have to back up, and checking that out about with what's going on with the client. I might notice the shift in mood or the shift in feeling state before they do. So this right brain to right brain communication, just as when the mother is attuned to the infant, when the therapist is attuned to the signals of the client, that is the change agent, the healing agent for trauma. It's really important that we as therapists can tolerate and recognize some of this really powerful affect that may be between us in the room. Because sometimes we, out of our own need to protect ourselves, we don't want to go certain places with the client. Sometimes for females especially, it's often hard to tolerate anger or aggression from a client. Sometimes it's difficult for therapists to tolerate sadness or to let a client just cry and let them feel. So knowing ourselves, being in our own therapy really, is so important for the trauma-informed therapist. Being able to regulate ourselves. I have to show up in the room and be able to ground myself and be able to be present, regulating my own emotions so that I can help the client learn to regulate theirs. Our trauma patients have very sensitive autonomic nervous systems. It's like their window of tolerance is reduced, and so they can get bumped out of this resiliency zone, the zone where they're feeling okay, very easily, and can go to hyperarousal or hypoarousal very easily. So being attuned to that is part of the repair. I have to stay regulated and help the client. My regulation helps the client to regulate. The therapist, again, is like, in many ways, like the mother, staying attuned to right brain communications in both the client and myself. And I think that's the piece that I really want to stress, that we have to stay attuned, have a dual awareness at all times.
One of the things that is so important are assessment tools, because very often clients are not aware that they have experienced trauma. They'll come into outpatient or intensive outpatient and they'll say, well, I have depression. They'll say, I have anxiety. They'll say, I can't establish a healthy, loving relationship. And they don't, oh, my parents were very loving. They were, they loved me very much, and no, there's no trauma in that relationship. As said by Judith Herman, the patient may not have full recall of the traumatic history and may initially deny such a history, even with careful, direct questioning. If the therapist believes the patient is suffering from a traumatic syndrome, she should share this information fully with the patient. Knowledge is power. The traumatized person is often relieved simply to learn the true name of her condition. By ascertaining her diagnosis, she begins the process of mastery. She discovers that she is not alone. Others have suffered in similar ways.
So we're going to talk about the importance of assessment tools, but this slide, and you have it on your handout, you can't really see it too well, but it shows how trauma impacts the brain structures, and how that leads to dissociation, how that in turn leads to the ability not to learn new information or new coping skills, how that leads to more traumatization. And one of the things with our trauma clients that you'll see is that if there has been developmental trauma, there's a tendency for re-traumatization over and over and over again. And this is some of the reason why that early dissociation doesn't allow for learning of healthy coping skills or of self-soothing and self-regulation. And so people end up getting themselves into situations that seem comfortable to them, but to some of us would be, oh my God, that's frightening, that's horrific, I'm not going into that room. So there's a list of different assessment tools, the ACE, the Adverse Childhood Experiences Questionnaire, the Trauma Recovery Scale. I'm not going to read them all. I do want to say the ACE is really great because it just really lists all the different things that might happen, as does the Trauma Recovery Scale. But all of these are well validated and reliable. Most of them you can get online, and you can go through them with your clients. But it's important to not just ask clients, have you experienced trauma, but to really go through some of these assessment tools with them.
The idea of like sharing with clients what we're aware of. You know, on a first session, a client isn't going to hear me if I want to point out how, you know, they experienced trauma necessarily. So it's kind of like just titration as far as that goes, understanding what the client's able to take in at any one time.
The first stage, as we talked about, is safety and stabilization. So we're doing symptom reduction, which is really, really important. So we want to establish bodily safety, giving the client tools to regulate themselves when they are not with us. Things like breathing exercises, things like resourcing, grounding. We want to establish a safe environment in the therapy room, in the treatment centers. We want to make sure that the environment is predictable, that it's safe, that staff are all trained in how to work with these very sensitive clients. We want to start things on time, end things on time. So a safe environment, and we want to help them find a safe environment, not just in treatment, but at home. And one of the key things I think most trauma therapists know this is really when they are getting re-traumatized or having a flashback or re-experiencing a trauma is to bring them back into the present moment. Bring them back into the here and now. What's going on right here, right now, in this moment? That abuser's not here, right now. You are no longer 12 years old.
In stage 2, we really want to support the clients in helping them overcoming the fear to begin the process. You know, sometimes when it's early enough trauma, perinatal or just after birth or in the first years before language, I mean, it's so terrifying because it's this experience they have, but they can't even name it. Or somebody's how dissociated somebody might have been during a traumatic experience. But helping them understand that they have the capacity to overcome the fear, to process what happened. We use techniques like distancing, right? If you're working with a client, you know, some of my clients love this, like you can just pause, because most people have a television, you can pause the show. So if it's getting if the memory is getting too much, you can pause it. Or as if you're on a train and you're seeing the scenery going by. So that's part of like really establishing this practice of distancing so clients can understand that it's not happening now. Working with the clients in the integration of the emotions, supporting the clients that the traumatic memory has been stuck or encapsulated. And the goal of working with the clients to help integrate it to the right brain and the left brain, rather than it just being stuck in this repressed or dissociated place. But wanting it to be able to be in both the right hemisphere and the left hemisphere so that the memory can actually be properly filed away. It isn't just these floating images of terror. Seeing if clients are looping or stuck and helping them work with the bodily sensations, and again, also as a therapist, not being afraid to, the pacing, like we don't want to go too fast, but we don't also want to go too slow out of our own fear.
So the third stage is integration and beyond, but I want to say that it isn't, the treatment isn't always linear. We always start in the first phase of safety and then go on to reprocessing, but then sometimes we have to go back to safety. And then sometimes we think we're at stage 3, but then something else comes up that we have to reprocess. So it's a fluid kind of stage model, but safety being the most important stage. So stage 3 we call integration and beyond. The goal in this stage is to increase the client's capacity so that they will be able to experience a broader range of feelings. Therefore, increasing their connection to themselves and to their aliveness. To deepen attachments, deepen connection with others, to help them get back in touch with, or maybe in touch with for the very first time, their values, personal goals, what's meaningful to them in their life, and help them to move into a stage of self-acceptance and self-love so that they can accomplish some of these things and can know that they deserve to accomplish. So in this stage, we're working with shame, self-acceptance, the self-love, and helping the client to move out back into the world with a broadened range of affect and broadened range of possibilities. We want them to move into joy, passion, aliveness, and even a sense